Welcome to this educational activity where Dr. Jeff Gooden from the Englewood Hospital and Medical Center discusses the appropriate use of opioid analgesics to manage chronic pain. The following audio is part of a certified educational activity titled Managing Chronic Pain While Avoiding Opioid Abuse, Science and Stories. Access the entire activity and complete the post-test at www.peerreviewpress.com/KQN. Downloadable slides and practice aids are also available.
Non-malignant chronic pain is often defined as any pain lasting more than 12 weeks that may arise from an initial injury, although there may also be no clear cause. The Institute of Medicine estimates that more than 100 million Americans suffer with pain, and nearly 25 million people have daily chronic pain. In addition, chronic pain is often accompanied by other health problems, such as fatigue, sleep disturbances, decreased appetite, and mood changes. Many patients with chronic pain require daily, around-the-clock, long-term opioid therapy. I'd like to begin by discussing the story of a patient. Her name is Mary. She's a 50-year-old female widow who is employed at Children's Daycare Center, but does not have children of her own. Mary recently presented to her primary care doctor complaining of dispersed neck and back pain that began approximately 6 months prior to presentation when she fell down the stairs at home. She did not seek medical attention immediately after the fall. When Mary presented to her primary care physician, she appeared tired, and the expression on her face was consistent with pain. She stated, "My pain has gotten so bad that I have to take off numerous days from work. Some mornings, I'm in so much pain that I can't even get dressed. And my job involves lifting and carrying infants and children quite frequently, which wreaks havoc with my lower back." Mary also said, "After I fell, I took acetaminophen to try to manage the pain, but it did nothing. I switched to ibuprofen, but over time, I've had to increase how much I take and how often I take it. I'm currently taking 800 milligrams 3 to 4 times per day, but this doesn't really provide adequate relief." After hearing all of this, Mary's doctor begins to further investigate her pain. So how do we evaluate chronic pain? The assessment and diagnosis of chronic pain in primary care is challenging because of its complex and multimodal nature, and restrictions imposed upon clinicians by time and resources. A systematic approach to identifying and diagnosing chronic pain often includes a comprehensive history, a physical exam, review of previous records, a psychological evaluation, interviewing a family member or significant other. Mary was diagnosed with depression 2 years prior to presentation that's currently being managed with duloxetine, 60 milligrams per day. She's not currently undergoing psychological therapy. She has a family history positive for alcohol abuse as well as addiction to illegal drugs. And Mary claims to consume more than 14 alcoholic drinks per week. On physical examination, she has diffuse neck and low back pain, multiple areas of tenderness to palpation. She denied numbness in her extremities. When we do X-rays and MRI, it reveals degenerative disc disease. She had no obvious fractures of the long bones or the spine. And a urine drug test is sent, which was negative for illicit or other prescription opioids. What are some of the tools that we use to assess chronic pain? Well, you're all familiar with the 0 to 10 scale. Some of you are familiar with the happy faces scale, where 0 is the happy face and 5 is the sad face. Oftentimes we'll use this for patients who have difficulty communicating or for children. There's also some other tools that we use to assess pain and functionality. So the CDC, during their recent recommendations for the guidelines on opioid prescribing, recommended this functional assessment tool called the PEG. And the questions are here. What number best describes your pain on average in the past week? What number best describes how, during the past week, pain has interfered with the enjoyment of life? And what number best describes how, during the past week, pain has interfered with your general activity? Now, the CDC gave us this really simple 3-question assessment tool, but they wanted to stress the point that as clinicians, we need to do something to assess our patient's pain and functionality. So let's look at Mary's PEG assessment. She rates her pain on average in the past week as a 7/10. She says that her pain interfered with her enjoyment of life as a 10/10, and that pain interfered with her general activities as a 10/10. So it seems like using this simple functional assessment tool that Mary's pain is interfering with her life in general. After discussing the diagnosis with Mary, you as her physician will begin to discuss management options for her chronic pain. You can provide her with a referral for things like physical therapy to try to make her more physically functional. And then we could broach the subject of pharmacological therapy. Some key questions to consider. As part of a multidisciplinary management approach, is Mary's pain severe enough to warrant treatment with opioid therapy? Well, Mary's been on over-the-counter analgesics, and she said that they were not providing her benefit. Another question to consider, is Mary at risk for opioid misuse or abuse? And we'll talk more about that, but remember we talked about Mary's family history, as well as her history of alcohol consumption. And if Mary's pain warrants treatment with an opioid, but she is at risk for misusing or abusing these medications, which, if any of these therapies, would be appropriate? Let's talk about opioids for the treatment of chronic pain. You have to recognize that opioids are just one tool in a large armament that we use to treat chronic pain, to relieve the physical distress of patients and to try to maximize their quality of life. In this regard, we as physicians wield the power to heal and relieve pain. However, as we've recognized, this power has the potential to contribute to harm, especially in the case of opioids. Prescription opioid use for the relief of non-cancer pain has risen dramatically in the last 15 years, contributing to a quadrupling of opioid overdoses and prescription opioid-related deaths. Let's talk a little bit about the pharmacology of opioids. When we use the term opioids, the ones you're probably most familiar with are those agents such as morphine, oxycodone, hydrocodone, hydromorphone, fentanyl, methadone, oxymorphone, and others. Some have a pure mu agonist mechanism of action. Some, if you remember back from pharmacology, can be mixed agonist-antagonists. There's even one that we use that's called a partial mu agonist, buprenorphine. And there are some that have a dual mechanism of action, like tramadol and tapentadol. So we have to recognize, as prescribers, that there's a delicate balancing act that we need to perform when prescribing a patient an opioid. We want to ensure the benefits of the medicine. What are the benefits? Reduction in pain, reduction in pain-related impairment, improvement in function, improvement in quality of life. But we also have to minimize the risks associated with opioids. Those risks are either bothersome or dangerous. What are some of the bothersome risks? We have things like somnolence or sedation, nausea, dizziness, constipation. Some others that you may or may not be familiar with, gonadal suppression, endocrinopathy related to opioids. The dangerous ones we're familiar with, respiratory depression. Why do people die on opioids? We think it's related to their respiratory depressant effects. And we can't forget about the risks of abuse, addiction, and diversion to opioids. So as clinicians, we need to understand how to screen patients for those things. Let's talk about the efficacy for opioids. Just how good are they to treat chronic pain? You know, opioids get a bad rap in the literature. When you look to the FDA and the CDC, they tell us that there's really no good evidence for the long-term effectiveness of opioids. They said that most of the randomized controlled trials were short in duration with relatively small sample sizes. In general, the outcomes look better on opioids than placebo from an analgesic standpoint, but some describe the pain relief as modest. There's really no great assessment of patient function, and nobody addresses addiction in these clinical trials. So as clinicians, we need to consider how clinical trials are done, the limitations of clinical trials, and really in my practice what I look at is an N of 1. If I start a patient on an opioid and their function improves and their quality of life improves and their family or significant other tells me that they're doing better, I continue the treatment. If I start an opioid and their function goes down, or there's any signs of abuse, misuse, or diversion, then we form an exit strategy and we discontinue off opioid therapy. One of the biggest challenges I find with the use of opioid analgesics is there's a variable response to opioids. Not all patients respond to opioids in the same way, and not all pain responds to opioids in the same way. For instance, two patients, same age, same height, same weight, same disease state. One patient gets put on a low dose of an opioid and does great. Their function improves, their sleep improves, their quality of life improves. The other patient gets put on an opioid and they don't do so well. The mechanism of action for opioids, from what we know, is most notably at the mu-opioid receptor. Taking you way back to pharmacology, the mu-opioid receptor is a G-protein coupled receptor that works through a second messenger system. Now, over the last decade, we figured out that there are multiple subtypes of opioid receptors. There's more than 100 polymorphisms in the human mu-opioid receptor gene alone. And we know that there's differences in patient to patient between how opioids are metabolized. Some of them are metabolized by the hepatic cytochrome P450 system. And as you remember, there are some people genetically, maybe 10 to 15% of the population, who are poor metabolizers because of this system. They are obviously going to respond to opioids differently than someone who's an extensive or a rapid metabolizer. So as prescribers, we're often going to need to try several opioids to find an acceptable balance between analgesia and tolerability. Now, I mentioned the CDC guidelines for prescribing opioids. These were put out in March of 2016. They proposed 12 recommendations to guide the day-to-day safe practice of pain management with long-term opioids. The recommendations state that non-opioid therapy is preferred for the treatment of chronic pain, and that opioids should be used only in the appropriate patient population when the benefits for pain and function are expected to outweigh the opioid risks. They also tell us that before starting opioids, clinicians should establish treatment goals with patients and consider how the opioids will be discontinued if the benefits don't outweigh the risks. And when opioids are used, clinicians should prescribe the lowest effective dosage, carefully reassess the benefits and risks when considering increasing the dose, and avoid concurrent opioid and benzodiazepine or other CNS depressant use whenever possible. So, let's talk about Mary. As part of her multidisciplinary approach, is Mary's pain severe enough to warrant treatment with opioid therapy? I think the answer is yes. Mary has chronic pain. It's severe and frequent, and it's resulted in decreases in her function and quality of life. She's failed conservative treatments. Let's ask the next question. Is Mary at risk for opioid abuse and misuse? The answer is possibly, and let's talk about why. We find there's a spectrum of patients who use opioids. Some of them are real patients who don't get enough relief taking lower doses. So what do? They take more pills. They're not necessarily substance abusers, they're patients in pain. But we also have patients that will use the medicines for reasons other than pain. In the patient population, we call these chemical copers. Let me take a pill to fix some of my ailments, like sleep and anxiety. On the non-medical side, this is where we run into dangers, because we have teens and college kids and all age ranges who want to experiment with opioids. We have the self-treaters for pain. We have some recreational users who will use once in a while. We have active substance abusers, and then we have those who develop the disorder known as addiction or substance use disorder. So what are some of the things we could do to evaluate the risks prior to prescribing an opioid? Well, one of the things we do is use validated questionnaires which assess the potential for risks of abuse or misuse. We do drug testing. The most common matrix that we sample is urine, but we could also do saliva and blood and hair and others. We check our state's prescription drug monitoring program. We review previous treatment records. We talk to the previous treating clinicians if possible. All of these things help a clinician understand a patient's risk for abuse or misuse on opioids. An example of one of the tools that we use is called the opioid risk tool. This is a 5-item tool, takes less than a minute to do, and it's a validated questionnaire developed by a fairly famous pain practitioner, Lynn Webster. So let's look at Mary's ORT score. The way these things are scored, as you see, is a 0 to 3 is a low risk, 4 to 7 is moderate risk, and anything greater than 8 is high risk. As far as family history of substance abuse, Mary gets the check boxes for a family history of alcohol and illegal drugs. Personally, Mary's consuming 14 alcoholic beverages per week. Some might consider that a personal history of alcohol overuse, so she gets the check box there. She doesn't get the check box for age or pre-adolescent sexual abuse, but she does get the check box for depression. So Mary's score totals a 7, which puts her at moderate risk. So we answered the questions. Is Mary's pain severe enough to warrant treatment with opioid therapy? The answer is yes. Is Mary at risk for opioid misuse or abuse? The answer is yes, at least according to Mary's opioid risk tool score. If Mary's pain warrants treatment with an opioid, but she's at risk for misusing or abusing these medications, which, if any of these therapies, would be appropriate? So let's talk about how as a community, how as a country we've come together to try to increase the safe use of opioid analgesics. There clearly has been a role of the clinicians in screening patients better, lowering the quantities of opioids that we write, being on the lookout for things like misuse, abuse, and diversion. Patients are playing their role. They come to the office all the time. They read in the newspaper and hear on TV the opioid abuse crisis. They understand they need to keep their medications safe and secure at home. We talk about disposal, how to get rid of them when they're no longer needed. The government, state and federal, has been very helpful in collaborating to address the opioid crisis. States have come up with guidelines for opioid prescribing, as has the government, the CDC that we've talked about. And industry has also done their part. So let's talk about what some of the technologies are to develop abuse-deterrent or abuse-resistant opioid analgesics. There are some physical barriers, which we'll talk about in just a moment. Let's make it harder to crush or chew. There are some agonist-antagonist combinations. Hey, let's put an antagonist in that the patient doesn't really see unless they crush the formulation and then it gets released. There's an idea that we could use an aversive component. Hey, let's make this burn if somebody tries to snort it. There's a prodrug formulation that doesn't turn into the active drug until it's inside the intestines. Remember, that's how prodrugs work. So if you smoke them or snort them or inject them, they're not going to turn into the active drug. These are some of the examples of ways that industry has made opioid products more difficult to tamper with. In 2015, the FDA gave us a guideline to developing abuse-deterrent opioid formulations. It really explains the FDA's thinking about how the studies should be conducted in order to get the language in your package insert, in your label, about abuse deterrence. And it talks about how they should do the crushing and tampering studies, how they should do the pharmacokinetic studies, how they should do the abuse liability studies. Let's talk about specific molecules with abuse deterrence. From a hydrocodone standpoint, in 2015, there was approval of an agent that forms a viscous gel that's difficult to get into or out of a syringe and needle. Just recently in 2017, a hydrocodone abuse deterrent opioid was approved that incorporates technology designed to resist extraction for abuse through the most common routes, like oral, intranasal, and intravenous. There are a number of abuse-deterrent morphine formulations available as well. In 2010, there was one of these agonist-antagonist combinations that I mentioned before. It contains extended-release morphine pellets with a sequestered core of naltrexone. In the core, naltrexone is an opioid antagonist. Many of you are familiar with naloxone. This is a brother molecule called naltrexone. As mentioned, if the patient takes the capsule intact, they're never exposed to the opioid antagonist. We wouldn't want them to be. But if the pellets are crushed, chewed, or dissolved, the naltrexone is released, and it lowers the likability. It blocks the euphoria associated with morphine and may even induce withdrawal. In 2015, another abuse deterrent, morphine, was formulated with inactive ingredients that make it harder to adulterate, harder to crush or chew, while maintaining the extended release characteristics. That's what we want. If somebody tries to manipulate a 12-hour drug, we want it to stay a 12-hour drug. And recently in 2017, a new formulation, a polymer matrix tablet with controlled release properties, as well as physical and chemical barriers that resist manipulation, was approved. The technology also results in a viscous gel on contact with liquid, making the product very difficult to get into or out of a syringe. So you could see how the abuse deterrent opioids really are going to thwart some of the abusers' attempts at getting them into other forms like powder or liquid. Let's talk about oxycodone. In 2010, a formulation of oxycodone was approved that forms a viscous gel that's also difficult to get into or out of the syringe. In 2014, a combination pill also containing an antagonist, this time naloxone, was approved. In 2016, a capsule containing oxycodone microspheres was approved, which makes it more difficult to manipulate and retains its extended release properties even when crushed or chewed. There's a 2016 formulation that contains pellets of oxycodone that surround sequestered naltrexone. More recently, in 2017, a formulation of oxycodone was approved that has inactive ingredients that make the tablet harder to misuse by physical manipulation, chemical extraction, or both. The data suggests that it's also going to be more difficult to abuse through an injection route. There was also the first immediate release abuse deterrent opioid formulation for oxycodone approved in 2017 as well. So when we revisit the key questions to think about with Mary, we've already said that her pain is severe enough to warrant treatment with opioid therapy. We've identified that Mary is at risk for opioid misuse or abuse. And then we said if Mary's pain warrants treatment with an opioid, but she is at risk for misusing or abusing, which, if any of these therapies would be appropriate? Well, as clinicians, we should certainly consider using an opioid with an abuse deterrent formulation if we're going to consider Mary for chronic opioid therapy. Let's talk about what the discussion with the clinician is going to look like for Mary. You may say, you know, Mary, based on your medical history, family history, and other factors, you're at higher risk for developing problems with opioid pain medications. However, your pain is severe enough that the potential benefits currently seem to outweigh the risks. So we can attempt to treat you with opioids, but we're going to choose one that has abuse deterrent properties. In addition, you'll need to have regular follow-up visits. These can include random pill counts, as well as urine drug testing. And rest assured, we're going to monitor the prescription database to make sure that you're not getting any type of controlled substances, including opioids, from any other clinicians. Mary agrees to your terms. In turn, we prescribe her an abuse deterrent hydrocodone formulation. And Mary agrees to come back in 1 week for follow-up. At that follow-up, Mary says that she has a good enough improvement in her pain that she's able to get through her regular workday. She said that she's scheduled to start physical therapy 2 to 3 times a week. A pill count said that she was taking her medications as prescribed, and Mary also gave you a urine sample to send out for toxicology testing. Today we discussed a number of issues about the use of opioids to treat chronic pain. We talked about the importance of establishing a diagnosis, doing a comprehensive history and physical examination, ordering and evaluating the results of relevant diagnostic testing. You're familiar now with the CDC guidelines and should really print them out for a reference, at least the quick 1 or 2 pager. You should be familiar with some of the REMS programs, Risk Evaluation Mitigation Strategies programs. Many of these are free and online and also provide CME and educate us about the safe use of opioids for chronic therapy, especially those extended release and long-acting formulations. You have to understand how important it is to monitor your patients on a regular basis through frequent office visits, querying the state's prescription drug database, which now you can check off many states, including your neighboring states, to see where your patients are getting their medicines. You should understand how to at least do a basic urine or saliva toxicology test. Use at least one of the validated assessment tools that we discussed during our talk. And remember, opioids are usually not unimodal therapy. It's usually not monotherapy. We combine our opioids with over-the-counter and adjuvant analgesics. We continue our patients' physical therapies and behavioral therapies, like stress management, guided imagery, cognitive behavioral therapies. So opioids are prescribed only as part of a multimodal treatment regimen. And although we discussed the newer abuse-deterrent opioid formulations, which we should be using especially for some of those patients at increased risk, they certainly don't replace comprehensive assessment and management of patients, because patients can develop abuse, addiction, misuse, or diversion at any point in treatment. I'd like to thank you for your participation today. I hope the program proved valuable.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerviewpress.com/KQN. This activity is supported by an educational grant from Daiichi Sankyo Incorporated.